Next we are moving to is infectious mononucleosis. The other name is, remember, the other name is glandular fever. So remember, it's a non-serious and temporary illness that is caused by Epstein-Barr virus. That is a type of herpes virus. Now, how it is spread? It is spread through direct person to person, like kissing. So the main route is saliva. So that transfer saliva contaminated with the virus. It is most prevalent among the young people, young person who are in schools, colleges, camps, etc. Now let us discuss about the pathogenesis of infectious mononucleosis. In people without antibodies, the Epstein-Barr virus, it will enter the body through the contaminated saliva. The virus infect the epithelial cells of salivary glands. Then it enter the B lymphocytes, a type of WBC that are present in the lymphoid tissue. The infection, it spreads throughout the body by bloodstream or by these infected B cells. So virus, it will cause fever and acute illness. The immune system produces antibodies in response to the infection. Now the antibodies, they peak around 2 weeks after the infection and stay in the body for life, providing immunity against the future infection. Even after the virus disappears from the blood, it remains in the body within the infected B cells. So these infected B cells, they become active and multiply. Initially, they will produce IgM antibodies that are used for diagnosis, and later they produce IgG antibodies that would provide lifetime immunity. Now there would be activation of CD8 T cells. They will kill the infected B cells, leading to presence of atypical lymphocytes in the blood. That would also give you a clue regarding the diagnosis. So these atypical lymphocytes, so these the cytotoxic T cells would kill the infected B cells, that lead to presence of atypical lymphocytes in the blood. Now the resulting symptoms would be the multiplication of these cells would cause lymphadenopathy, generalized swollen lymph nodes, and hepatosplenomegaly, enlarged liver, spleen, and sure thought may occur due to either the death of B cells or early viral replication in the salivary glands. Now the incubation period is 30 to 50 days in the young adults. The prodromal period is 3 to 5 days. Symptoms include malaise, muscle ache, headache, fatigue. The clinical features, you would see fever, sore throat, bilateral cervical lymphadenopathy, swollen neck, lymph nodes. Less common symptoms, there could be splenomegaly, enlarged spleen and liver, hepatomegaly, So remember Epstein-Barr virus, the complication could be they can be oncogenic, as they could be associated with the Burkitt lymphoma and the nasopharyngeal lymphoma. Now this diagram represents the pathogenesis of infectious mononucleosis. The Epstein-Barr virus, as we know, it is transmitted through intimate contact like kissing that leads to pharyngitis, that is sore throat. The virus is shed from the epithelial cells into saliva. The Epstein-Barr virus enter and infect B cells in the lymphoid tissue. Infected B cells, they will undergo activation, polyclonal activation, that leads to proliferation of B cells, that results in secretion of antibodies. They are IgG and IgM, and activation of CD8 lymphocytes. So the proliferation of these immune cells cause symptoms of infectious mononucleosis, that could be lymphadenopathy, hepatitis, splenomegaly, meningitis, pneumonitis, skin rash, etc. In certain individual with genetical susceptibility, it contributes to the Epstein-Barr virus contributes to oncogenesis or cancer development. So it can cause nasopharyngeal carcinoma, that is a type of cancer in the upper part of the throat. It can lead to B cell non-Hodgkin lymphoma and the Burkitt lymphoma. Now what would be the laboratory findings in infectious mononucleosis? First of all, the blood findings. Total leukocyte count increases up to 10,000 to 20,000. In the DLC count, differential leukocyte count, you will see lymphocytosis, that is increased lymphocytes, increase in both normal and atypical lymphocytes that could be seen. Relative neutropenia, that is decrease in the neutrophils. So atypical lymphocytes that could be found. There is a decrease in CD4 T cells and increase in CD8 T cells. Apart from that, you can do is the best test would be the test that is Paul Bunel test, that is used to diagnose infectious mononucleosis. Here a blood sample is taken from the patient. The patient serum, that is the liquid part of blood that is without cell, is treated with guinea pig kidney to remove the non-specific antibodies. The treated serum is mixed with RBC from sheep, horse or cow. So this mixture is observed for agglutination, that is clumping of the red blood cells. Remember, a positive titer of 40 or the more indicates positive test. So remember, heterophile antibody peaks during the third week of infection in 80 to 90% of cases. So these antibodies can be detected for about 3 months after the infection begins. Remember, the test is less reliable in children who are under the age 5 years and in elderly patient. The monospore test is a newer, more sensitive and quicker alternative test to the Paul Bunner test. So in the summary, the Paul Bunner test determines the heterophile in the patient serum by observing the agglutination of red blood cells from certain animals.